All right. So give us just a second. We're running just a couple of minutes behind, but I think we should be in a good spot here. I'm going to get, my name is Luke Haynes. I'm going to be talking to you about rotator cuff and shoulder pain this evening. But I'm going to get Ashton on board here just a second to give you a few just preliminary things to talk about to get the ball rolling here. So Ashton, if you can jump on.
Hi guys, my name is Ashton. I'm just going to touch on a couple of things. At the bottom of the screen, it may be in a little different spot if you're using your phone, there is a Q&A tab and a chat button. Casey and I will be monitoring the Q&A and the chat throughout the course of the webinar. So if you have any questions, please feel free to throw those questions in there. If it's a question that Dr. Haynes is going to answer, then we'll probably just let you know that he's going to answer it. If it's one that he hasn't answered yet, then we will be sure to ask it for you during the Q&A session of the webinar. Also, you should have received an email this morning with a workshop or a worksheet that he's going to answer all the questions to throughout the workshop. So if you have any questions on that, let us know. If you did not receive that, please let me know in the chat and we can shoot that over to you as well. I'm going to turn it back over to Luke now.
All right. So again, if you have questions, hit that Q&A button or the chat, whichever Ashton said to hit. I don't remember. But go ahead. Let me get rid of this little button that's in my way. All right. So rotator cuff and shoulder pain. Right off the bat, the very first question that I'm going to ask is, has anybody had shoulder pain in the last 30 days? So, and gentleman over here is raising his hand. I definitely raised my hand. I'm definitely a member of the Shoulder Pain Club. We'll talk a little bit about what happened with my shoulders and how I've taken care of them over the past 35 years since they were injured. So we'll do that. And what I really want you to focus on is, and we'll see how this plays out, is what do you do when your shoulder causes you pain? For me, most of the times, unless I'm doing something really silly, it's how I sleep. I tend to sleep laying on my shoulder right here, and I wake up in the morning, it's kind of stiff. And so that's where I tend to get my problems with my shoulders. So think about that as we move through this. And I will also apologize. This is doable on through the Zoom, through the virtual situation. It's not quite as good as when we do it live. Fortunately or unfortunately, however you want to look at it. Tonight we're doing it in this virtual format. I would love to see us be able to get away from the virtual situation, but given the mandate that the governor sent down today, we're taking all of this one day at a time. We are open. We had a workshop in the office last week, late last week. So we're still doing that. We'll just see what happens as we move forward with COVID and so forth. So anyhow, one of the first things we want to look at is talking about what is the rotator cuff. And forgive my young man here in the drawing. Three things we want to look at with the rotator cuff. Number one, we want to talk about the bones that comprise the shoulder joint itself. We want to talk about the structure of the shoulder joint. And then we're going to talk about the muscles themselves that make up that joint. So what is the rotator cuff? Let me move past that. You'll have to forgive my technical issues here. All right, so let's talk about the bones of the shoulder first. The very first one, the upper arm bone or the humerus, and you don't have to remember the fancy words that I'm going to throw out. But the upper arm bone. The second one is the shoulder blade or the scapula, and the third is the clavicle or the collarbone. Now, there's a really important piece out on the edge of that collarbone and the shoulder blade. It's called the acromion, and we're going to find out a little bit later that a lot of the issues that we deal with the shoulder, the rotator cuff, have to do with this outcropping of bone right here with the acromion. So let me move on past that. So those are the four bones that make up the shoulder. The next part is the joint itself. So I've highlighted a couple things here in green. The very first part is the ball of the upper arm or the humerus. So the ball comprises the rounded part, and then on the socket side is just the round, but it's the socket. So similar situation with the shoulder and the hip, actually. Big difference, you can tell the shoulder, it's got a fairly small, fairly shallow socket, whereas the hip is got this big, deep, it's called the acetabulum. It's a big place for the ball to go in. It's nice, stable, it's sturdy, and it's not going to go anywhere. The shoulder has 6 degrees of movement in that joint. It's the most mobile joint in the body, which is the reason why we get all of these different motions that we get with it. But it's also the reason why it can also be one of the more complicated shoulders as far as injury and pain and dysfunction. So that being said, we've got the ball, we've got the socket. It's called a ball and socket joint. And so my analogy on the shoulder joint, we talked about the hip. It's a big socket with a lot of stability there. Well, the shoulder blade is more like a golf ball sitting on a golf tee. And if you've ever played golf and tried to set that ball on the tee, you know that it has to be really tight right on top or it's going to fall right off. And that's kind of how that shoulder joint plays. It allows for a lot of movement, but it requires a lot of control. And that's what the rotator cuff muscles do, is they control the ball sitting on top of that socket or on top of the tee. So we'll look at the muscles next. So the muscles, there are 4 muscles that comprise what we call the rotator cuff. They're really just 3 that do the full job. There's one, and you can see it up top. It sits up top. There's one on the back side of the shoulder blade, and then there's one more on the front side of the shoulder blade. And together they just create this cuff, and that's why they call it a cuff. It's a cuff of muscles that holds the ball into the socket. And again, it's a really mobile joint. The muscles themselves, I'm going to tell you their names. You don't have to remember this. The upper one, and honestly, this is the one that gets, whenever there is an injury, whenever there is a significant tear, it's almost always this upper one. It's called the supraspinatus. The one below it is called the infraspinatus, and those are called that because that's called the spine of the scapula, and that's above it and that's below it or infra to it. Third muscle that's really not involved with a whole lot of movement, a lot of problems, it's called the teres minor. It technically meets the definition of a rotator cuff muscle, but again, it's usually not involved with pathology or pain or dysfunction, but it is part of it, so we'll include that one. And then finally, the 4th muscle that sits on the front side of the shoulder blade. So it's on the front of the shoulder blade and it sits up against the rib cage, and that's the muscle that helps pull our arm back across and over towards putting it onto our stomach. So those are the 4 muscles that comprise the rotator cuff. And again, the one that typically is more problematic is the one up top, the supraspinatus. We talked a second ago about the acromion. Well, here's the acromion, and you can tell in this slide here, there's not a whole lot of space there. And we're going to talk about that a little bit more when we talk about the main causes of shoulder pain. So one thing that's very important with a shoulder and a rotator cuff problem is the things that have to work together to enable this shoulder to move up and down or side to side. The things that have to work together, and we'll talk about how we've started really focusing on this with our treatment. Seems silly, but the neck is incredibly important to proper function of the shoulder. We have a lot of muscle that comes off of, literally comes off of the shoulder blade and the acromion and even part of the collarbone. And it all comes up and attaches into the base of the skull and along the neck itself. And that's the big muscles. There's a lot of smaller muscles as well that attach onto the neck. And so we'll see that whenever we have a problem with our neck, let's say we have a hard time rotating our head to the right or to the left or extending to looking up, that can have a big impact on the function of the shoulder, both in motion and in strength. So we really have to look at the neck, number 1. Number 2 is the collarbone. It doesn't seem like it's that big of a deal, except the collarbone is the only bone that attaches the entire upper extremity to the body. And it's done in this one little section where the collarbone comes and attaches onto the sternum right here. So the function of the collarbone is it holds the shoulder onto, it's the structure that holds it onto the body, but it also helps guide that shoulder as it comes up. So the collarbone is going to rotate just a little bit as we bring that shoulder way up high. It's not all the time that the collarbone is impacting pain or strength or motion, but whenever there's an issue and it's not functioning well, it's not moving how it should, we have to look at that to make sure that it is doing its job how it should, because it could be responsible for the problem. The other part is the shoulder blade. Let's say you had a fall, you had an issue, something happened, and you've been dealing with shoulder pain out here for a while. One thing that instantly happens is we tend to, and I'm going to see if you can drop that down a little bit, we tend to just hold that arm right there. It hurts. Easiest thing is don't move it so that we're not dealing with that pain. What happens is that shoulder blade seems to almost just get stuck there. We've held it there, the muscles get tight, they get stiff, and before you know it, we're trying to move like this, or what I frequently see is a person will lift their arm and they'll do this number right there. Well, the shoulder blade is stuck, and so it's not letting that the shoulder joint move like it should. So movement of the shoulder blade, incredibly important as well. Lastly, we start to look at the function of the rib cage. Now, the rib cage has just as much to do with the neck as it does the function of the shoulder. I mentioned that I tend to sleep over in a side position. Well, what tends to happen with this first rib up here is if we spend a good bit of time here, that first rib can actually come up like a little handle, and it really impedes the movement, the function of the neck, as well as the muscles that come off of it and over to the shoulder. So we have to take a look at that first rib, sometimes the second rib, but really that first, and how it impacts the movement of the shoulder. All right, so a little graphic here. We're going to get out our worksheet and we're going to answer a few questions. So the first questions, 1A, what is the rotator cuff? It is a group of 4 muscles that move the shoulder. 1B, the shoulder is a ball and socket joint. And then 1C, the 4 areas that work together for shoulder movement is the neck, the collarbone, the shoulder blade, and the rib cage. Now, as I go through this, down at the bottom of your screen, you see a web address. It's freeshoulderscreen.com. I'm going to mention this several times. You may be on this virtual workshop because you have concerns about getting out. You can go to the freeshoulderscreen.com if you want to. You can sign up for just a free screen, what we're calling a free shoulder screen. I'm going to talk about that more a little bit later. But most people are going to be on here simply because they're dealing with some shoulder pain and they want to get some answers. And I'm going to tell you a lot of times these answers are going to come whenever I can take a look at it and I can tell you a couple of things that maybe you can do. So I'll reference that again in a little bit. But that's the first 3 questions right there. The next part, how did I become to specialize in shoulder and rotator cuff treatment? Well, I'll be honest, it really started with injury to both of my shoulders as a 16, 17-year-old high school football player. That was a lifetime ago. One play I was in, I played linebacker. I went to make a tackle. Somebody landed on top of me and dislocated the shoulder. Go to the sideline, get it reduced and back in place, go back in the next play, and the same thing happens on the left shoulder. So I then come back and put it back in and then go back. Fortunately, it didn't happen again. So that was at the age of 16 or 17. At that age, we can bounce back from almost anything. It's not a big deal. I never thought anything else about it until 15 to 20 years later when I'm trying to teach my 10-year-old how to throw a good pitch. And all of a sudden, the thing just explodes, and I've got terrible pain. And so what I went through with my shoulder is really the impetus of where I learned the best way to take care of the rotator cuff. A little bit more on that story. When I did decide to take care of it, I was a younger therapist, and by younger, I mean it was 10, 15 years ago. I ended up having surgery on this right shoulder. Honestly, I was a horrible patient. I went and played golf at 3 weeks. I did things I should have never done, and I blew it back out. So during that time, then I learned some of the things that I'm going to talk about that really enabled me, 1, to manage my pain, 2, to restore my motion, and 3, to get my strength back how it needed to be. And so that's a big part of where I learned what we're doing here, partly some on-the-job training. But it wasn't all that. So I got my bachelor's degree in physical therapy the last year that they offered it at the bachelor's level. The next year they moved it up to master's. Got that in 1994 from Texas Tech. I went on to ultimately get my doctorate in physical therapy in Boston in 2012, which has now been 8 years ago. Some of my achievements: I am the author of the Neuromuscular Dry Needling series. This is a series of, we'll talk a little bit about dry needling. I use dry needling extensively with treatment of not just the rotator cuff, but throughout the body. It's an extraordinarily beneficial process to really get rid of some pain whenever we're dealing with it at that level. Most of the pain, let's say you've got a pain that's a 5 out of 10 or above. We need to get that pain down. We need to get it under control so that we can really get to what we want to talk about, which is the flexibility and the strength and the stability of that shoulder. Anyway, I got double certified in dry needling, and then I went and created my own method of dry needling. I teach that to clinicians across the state right now. I'm about to start teaching nationally. And matter of fact, we had a course this past weekend with different therapists. I've taught chiropractors, doctors, there's a lot of folks that we've helped with this. From time to time, I also will teach collegiately, and one on my clinical experience. And these numbers are a little bit old, but I've treated or supervised over 500,000 patients. And I've dry needled over 30,000 patients with approaching now probably 200,000 different needles. Again, a lot of people, when I mention needles and dry needling, get really timid and shy. I hate needles myself until I learned how beneficial they can be for dealing with the pain that I was dealing with, both in my shoulders and in my cervical spine and my lumbar spine, where there's no medication, there's no drugs. It's just a fantastic way. Knock pain down so we can get on to real business there. So that's who I am. So let's talk a little bit about getting back to normal and what we should look at, or what we had looked at traditionally with our traditional physical therapy. And I'm going to tell you that the majority of physical therapists out there still practice with this model. One of the very first things that I did after graduating from college was to go and get some advanced training, and it was very helpful. But really what it ended up looking like with traditional therapy is 25% of the people, and I'm just looking at shoulders right here. 25% of those shoulders that came in, we did great with them. You know, the pain went away, they got back to normal, and there weren't any issues whatsoever. Just fully successful, great opportunity, great time in therapy. There were 25% that horrible outcomes. Pain stayed around. They never got motion back, and honestly, they questioned whether they should have just jumped straight to surgery, and probably ended up anyway. And then a full 50% of patients, they felt like they did a good job. You know, they were doing their exercise, they were moving a little bit better, but they were still dealing with pain, and they still had questions in their mind if they probably needed to have surgery. And these numbers look terrible, but that's still what we look at when we consider traditional physical therapy. So what I did is applied, number one, the things that I had learned through dealing with my own shoulders, but then what I had learned through some more advanced training that I did in the development of my dry needling program. We learned a whole lot more about some really good ways that we could take care of the shoulder. And a big part of it, honestly, is in treating all four of those systems. And those four systems were, number one, we got to look at the neck. What is the neck doing? Is there some limitation there that's affecting it? Is there a first rib problem? Is the shoulder blade stuck? Is there some issue with the collarbone? And we have to look at all four of those pieces in order to really address the movement issues that we're dealing with. So once we integrated all of that together, now all of a sudden, 90% of the people that we see, we can treat them and never have to have surgery. Pain is very minimal, and they're back to a functional movement level. There's still about 10%. I don't have the numbers right here. Let's say there's 20 people on this webinar. I have no idea. Still 10% of that probably going to have surgery. There's just some tears. There's some pathology that's too significant for us to be able to overcome. But I know myself and a lot of my surgeon friends, they would definitely rather avoid surgery if at all possible. The tears after I blew my shoulder back out the second time, definitely if they took the imaging, it would say that it would benefit from surgery. I don't really deal with pain that much anymore. My strength is fine. My motion is good. So I've elected to deal with a little tearing in there. I'm okay with that. I can function. I can do the things that I need to do, and that's what I'm looking for. So as a therapist, one of the things that I look at whenever somebody tells me that they're dealing with a shoulder problem is their pain reproducible? Is there something that they do that makes it worse or makes it better? Again, I know that my own, if I'm sleeping here, I know it's going to be a lot worse. And so that's one of the big things that we look for is what is the activity that we do that reproduces that. And the good thing is that if there is something that reproduces it, if it's not just constant, if it's a constant pain, it could be that's going to be one of those 10% folks. But if there's something, even if it's, getting milk out of the fridge, if it's, putting your hand behind your back, if those are the things that make it worse, then there's good news that we can usually reduce that pain. So back onto that little worksheet, 3A, if your pain, numbness, or tingling is reproducible, then it's reducible. The next one, in the past 30 days, the worst pain I've had was, and this is kind of a fill in the blank thing. So mine have actually been in pretty good shape. I haven't had any real issues over the past 30 days. So maybe 1 out of 10, 2 out of 10. We've all heard that pain scale of 0 is no pain, 10 is your worst imaginable. Probably 2 at most for mine, and it would have been very fleeting. Fortunately, it wasn't significant enough that I can really remember what it was, so I'm going to call that a win. More importantly here is what was going on whenever that pain came on board. Was it, again, for me, it's sleeping like this. I know I shouldn't do that, but I'm also human, and once I go to sleep, I'm not responsible anymore. So for a lot of people, it's reaching overhead. A lot of these overhead activities really create issues in the shoulder. For some people, it's lifting. For a lot of people, it's something simple as getting milk or tea or something out of the refrigerator. Hand in the back pocket is, especially for men, we put our wallets back there. That can be a real issue for women, putting the bra on, really trying to get those arms back there, or even coming up, fixing the hair. And then for a lot of people, if they happen to be down on the floor, just using the hands and the arms, the shoulders to get up from the floor. So in your regard, consider what, over the past 30 days, what is the worst that your pain has been? And then what were you doing when you had that? And again, we're looking to be able to reproduce this. If there is a cause, we can use it. You can usually elicit a change in the shoulder, and that's when we see the hope. That's when we think that we've got a shot at taking care of this. So a quick cause of problem scenario, and this is whether this is a shoulder problem. This could be any problem that we face. It could be a marriage problem. It could be anything. 3 things that we can do. Number 1, we can ignore it. And I'm going to say with shoulder problems especially, that's usually what we do is we ignore it, hope it'll go away, hope we don't have to see the doctor, hope we don't have to have surgery, and things of that nature. I'm going to use an analogy of potholes in the road. So I live on the far west side of Weatherford. Well, let's be honest, for a couple more weeks, then I'm headed out to the country. But right now where I live, we have a lot of potholes around on this side of town. The city, God bless the city, we don't seem to get a lot of the trucks coming about to fill in those potholes. So those potholes get ignored, and they're going to continue to get worse. Same thing with the shoulder pain. It's not going to get better just ignoring it. You might put it off for a while, but at some point, something's going to reach ahead. Something's going to take place that it's going to need a little attention. The second thing we can do with any problem is we can alter that problem. In the case of the potholes, and I said they never come down. They actually did come down. It's been about a month now. So about 200 yards from the house, there's a hill. There's on a little incline. And so there's a lot of traffic and a lot of wear and tear on the road right there. Well, there's about an 8-foot section that has 4 or 5 decent-sized potholes right there. So they did come in and they filled in the biggest pothole, but they didn't fill in the rest of them. And so that was a month ago. Move forward to today, all of that asphalt is now moved out. It's all the same problems are still there again, and we've still got the potholers there. So with the shoulder, what does that represent? Well, with the shoulder, and I'm using the shoulder as an example, it can be any part of the body. That's our drugs and injections and our surgery. And the reason I mentioned these three, the drugs and injections specifically, they're there to knock some pain down. But what we've learned is that most shoulder problems are a mechanical problem. There is some tightness in one of the muscles of the rotator cuff, or there's a neck issue that's creating some dysfunction out here. Can there be some tearing? Absolutely, there can be some tearing. We're going to talk about that in a minute. There can be some the tearing of the cartilage or the labrum. I have some tearing in both of the labrum in my shoulders. And in surgery, we can go in and we can do surgery and we can change that, and that can repair a tear. But if we don't change the function, the mechanical problem that started it in the first place, then it's just going to be a function of time until we get back to that same problem. So even the surgery, in my opinion, is considered just altering the problem. It hasn't changed the strength, the flexibility, and the mechanical operation of the shoulder itself. And so what can we finally do? Well, we can handle it. And again, that's what I chose to do with my shoulders. In that case, in my road analogy, you can fill in potholes, but until you repave the whole thing and get it mechanically sound as a road should be, then you're going to keep having that problem. But that's how you handle the road problem. In the shoulder, it comes down to getting natural treatment and learning to manage your symptoms. It comes down to finding which muscles of the rotator cuff are functioning normally and which ones are not. And then how do you get those that are not functioning normally to do so? It involves looking at those other four systems to make sure that they're functioning properly as well. And that's how you learn how to handle the shoulder problem, even if there is some pathology, even if there's some mild tearing. So onto the worksheet again, things to do when faced with a problem. The number one single biggest mistake shoulder pain sufferers make is they ignore it. And then the three things that you can do about your rotator cuff and shoulder pain right now is 1, you can ignore it. 2, you can alter it. Or 3, you can handle it. You've taken the time, you've looked at our ads on Facebook, you've gotten the emails, we've bombarded you with a lot of information. You're aware that there's an issue, you're aware that there's a problem. I'm going to encourage you to not ignore it any longer. Don't alter it. Let's figure out how to handle that. And again, I'm going to point down to this freeshoulderscreen.com. If you want us to have us take a look at it, do that. And we'll talk in a minute about how to do that. So the 3 main causes of shoulder pain. Now, there are tons of potential causes of shoulder pain. If it was just 3 simple things, shoulders would be simple, and it wouldn't have taken me 25 years to really get it figured out. But I'm going to lump everything into 3 little categories. But I want to talk a little bit about imaging, especially with the shoulder. Imaging gets really, really important with what we do with that imaging. So what does normal imaging look like? Well, this is an x-ray of a fairly normal shoulder. I don't see any significant spurring. There's nice joint space between the ball and the socket over here. That looks good. There's a little spur right up top, but we don't tend to get worried about the spurs up top. We get more concerned about the ones that drop down. So I look at this and I'm thinking this is a fantastic shoulder x-ray. The bad thing is this person could be coming in to see me with pain that's sitting at an 8 out of 10. So we see the structures and look good, but structures and imaging doesn't tell us about pain, and it doesn't tell us about limitation of movement. We can't move that thing and see in the image and see what's happening. So we really like the imaging, but we don't treat that picture. We're treating the shoulder that's going on. So imaging, you have to be careful on what you take away from that. So there were some studies, and this can be kind of boring, so I'll just jump through it. The MRI studies of adults who have no shoulder pain show that 20% at least have partial rotator cuff tears, and 15% have full thickness tears. That's 20% have 15%, 20 have partial tears, and 15 have full thickness tears, and that's significant. That's a lot of folks. The interesting thing down people over 60, it jumps up to 50% have shoulder pain and have rotator cuff tears. Well, they have no shoulder pain. And most of the time, these high numbers, that's pathology that we don't even know about. We don't even have any pain, and we're dealing with that. Study on professional baseball pitchers showed that 40% had either partial four-thickness tears, and yet they had no pain while they were playing and remained pain-free even 5 years after the study. The baseball players are some of the world's worst when it comes to shoulder problems because that shoulder goes through so much abnormal movement that they are really prone to more tearing. Yet a lot of times they have that and they have no pain. So the translation here is, do not panic if your imaging shows a rotator cuff tear. It's not necessarily associated with your shoulder pain. I have a perfect example. I had a young lady that actually she was a patient of mine. She actually came back to the workshop a couple of days last week. She had full thickness tears of all three of the main rotator cuff muscles. There was absolutely no reason why any competent surgeon wouldn't say, look at that, we need to go have surgery. And in fact, he did tell her that. She didn't want to have surgery. She wanted to try to give it a chance to see if she could let it heal on its own. And so hers is an extreme example, but we took about 4 months, and she was very diligent. She did her homework. She did a lot of hard work with it. But she now, even though she has those major tears, her pain is very minimal. Maybe a 1 out of 10. And then she's got, she's in her 70s. She's got decent motion for a 70-year-old. And I say decent motion. I'm in my early 50s. I don't have 100%. I have about 95%. I'm going to be honest. I can live with 95%. I don't have to be able to reach way back behind me. I need to be able to get up in the top of the shelves and do everything I need to right there. And I'm perfectly fine with that. So again, the take-home message here, the bottom line is, even if there's some tearing in the imaging, we need to be careful that we don't automatically assume we need to go have surgery. Tears can heal, and we can overcome those issues. My second thought on imaging is the concept of vomit and barf. So what does vomit mean? Vomit is a victim of modern imaging technology, and it's the brainless application of radiological findings. And really what it means is treatment based on imaging findings alone without any clinical correlation. And so, again, a lot of my surgeon friends would absolutely take a look at their imaging and say, that's interesting. Well, let's try some other things before we slice and dice this thing. Once it's opened, it's a lot harder to make it improve after the fact. Because, again, we still have to restore the movement, the flexibility, and the strength even afterward. So again, the three main causes of shoulder pain. Number one, we want to look at the neck. We want to see what's happening here. A lot of times, a person that's dealing with a neck issue, whether it's from spending too much time with the phone down here, maybe they've got some stenosis, some loss of some disc height, some arthritis. With that, it starts to pinch down on the nerves that come out of the neck. And we'll look at that just really quickly here. So the picture on the left, the diagram and the x-ray, is looking at a person face on. And so this disc, the example is that it's lost a little disc height. So those nerves are being compressed a little bit. Well, where the nerves that supply the shoulders come from is at C5, C6, C7 right here. And that's where, whenever we have stenosis, that's where those nerves get more compromised. Unfortunately, it's also the nerves that give the nerve supply to the arm. On the opposite side, we've taken a look at a picture of the person looking the other direction. That's actually backwards. This guy should be inverted. Anyway, so this is the impact that it can have on the central canal, the spinal cord itself. So as these discs compress down, the little areas to the side, let's consider that those are bone spurs. They're there's lips on the edge of the vertebra. And those can really push out into the column and create a lot more tension on that as well. And that can create the radiating symptoms out into the arm. So we have to be careful that we definitely want to look at the neck and see the impact that it has coming out to the shoulder itself. A lot of times that can create the dysfunction, the movement problem that we're dealing with. We take care of the neck, and a lot of times we find that we can take care of the shoulder by dealing with the neck first. The second thing we want to look at is the rib cage, especially that first rib. Again, let me pull these pictures up. We look at that first rib, and here we're looking at it, it's the green structure. And so when we look at it in the picture on the right, the nerves that come out and form what we call the brachial plexus. The brachial plexus is the grouping of nerves that comes down, that runs all the way down the arm. Well, they come out of the neck and they go right on top of that first rib and right below the collarbone. So if, and I mentioned that first rib can raise up, especially if you sleep like such. So there's not a whole lot of space already to begin with between the first rib and the shoulder of the collarbone. So if that is tilted up a little bit, it compresses it even further. And so what happens, we can get a lot of this business shooting down the arm. We can get a lot of numbness. We can get some loss of strength. Definitely we get the pain associated with that. So that first rib is very important for proper shoulder function, but also management of pain that's going on out there. And so with the neck issues, again, the things that we're concerned about are the limited range of motion. Basically, the neck has three planes. It moves up and down. It rotates side to side, and then it leans side to side. So if you have a shoulder issue right now, I'd encourage you, evaluate, look at yourself, see how your neck is functioning when you move up and down, or if you rotate, or if you lean. See if that makes any of that issue going out to the shoulder. See if that makes any of it better or worse. More often, it's going to make it a little bit worse if there's a neck involvement. So the neck gets really critical in problems with the shoulder. The second part is what we call impingement. Now, impingement is anatomically probably the closest issue that we actually deal with out in the shoulder. We talked about this top muscle being the one that's more involved in tearing and in pathology. And the reason is for that is for its location here at the acromion. As we look at the picture on the right, you can tell there's not a whole lot of space in here for that muscle. And that's with the muscle stationary. On the left, again, there's what we call the bursa. You've heard of bursitis. Well, bursa is just a cushion that sits in this little space right here. I've taken them out of that picture on the right just so that you can see the amount of space. But if the bursa gets irritated, what does it do? It expands. It gets bigger. And the bad thing is when that happens, we lose even more space in this space below the acromion. And so the net result of that is whenever we go to lift that upper arm up, well, we're just going to jam right in to the acromion right there. And when we do that, we create more inflammation and we create potential for tearing right there. So here we have trouble reaching behind the back. Again, this is side sleeping on the raised arm. Again, the space gets very small, and if there are any bone spurs, the fraying of the tendon can lead to a tear. And again, when we talked about that bone spur, it tends to happen right here, right where the collarbone attaches onto the shoulder blade. That can be an issue because it's going to come down into that muscle right there, if you can see that. And if you jam it up, it can push down into it. Or if you rotate on it, it can do a lot of that same thing. And so that's something we have to be very cautious of. So impingement really makes that more complicated. Okay, so I've got a little video here that kind of demonstrates that even better. I'm going to move way over here. So here we are with the shoulder. The muscle that's highlighted, that orange-looking muscle, is the supraspinatus. It's that main rotator cuff. And we're going to rotate a little bit here, and we're going to see how tight that space gets. You can tell, even as it's just moving up and down, lifting your arm to the side, that there's not a lot of space right there. Well, I went away from it. Hang on. I want to finish that. Let me get back to it. Yeah, just not a lot of space in there. So if this thing is already irritated, it's going to have a lot less space to move around. And that's where we get our impingement, and that's where we start to see we can see some tearing with that. You get under there and you can see that it's just not functioning well. And so whenever we're dealing with that function problem, and let me move on from there. How do I do that? There we go. So I mentioned the shoulder and lifting up like this. Well, that's because of impingement right out here. And so, and I'm going to try to get this where you can see this. So normally, so we've got the acromion right here and the ball that sits in the socket right here. Normally, this is going to come up and down very smoothly right here. But whenever there's impingement, what happens is it comes up, it jams, and it brings the whole thing up and down. So we're hitting that muscle, we're getting it more irritated, more inflamed, it's getting weaker, and it's getting tighter all at the same time. So one of the things we have to do is get that down and get it in the socket how it's supposed to be, so that it can then rotate and come up and down like it's supposed to. So that's the impingement part. Third and final is poor posture. I know this seems very silly, and I'm going to have you try this on your own. So this is just an illustration of what posture can do to the weight of the force that comes down through the neck to, and the force goes through C5, C6, C7, that lower neck area, which is where the nerves come out. So in normal posture, the head weighs 10 to 12 pounds. That's a lot of weight. That's still a lot that happens. But you look, we move forward to where we're really cranked down. We move that center of gravity forward. Then all of a sudden, that same weight is converted not 10 to 12 pounds, but it's 60 pounds. And so that's a lot of degeneration, a lot of wear and tear in that area, a lot of stenosis and narrowing for those nerves coming out. So what I want you to do right now, if you will, and I'm going to do it myself, and this is not the best place to do this, but we're going to give it a shot. So I'm sitting up nice and tall. My chest is out, my shoulders back. I'm going to bring my shoulders up, and I've got nice, good motion right there, and I'm going to bring them right back down. Now I'm going to slouch like a 16-year-old. I'm going to drop my head forward. I'm going to roll my shoulders forward. I'm going to just take this really poor posture. You know, like maybe I'm sitting here getting in a text conversation with somebody, or I'm watching Facebook. So I'm here. Now in this same posture, now I want to lift those shoulders up. And if you did it with me, you all of a sudden realize that posture is incredibly important for shoulder movement. And so one of the things we definitely preach a lot is with the neck, number one, is get that thing tucked back a little bit, throw those shoulders back, throw that chest out, and that's going to have a big difference on how the shoulder functions. So posture, incredibly important. So onto the worksheet. Again, number 6, the top three common causes of shoulder pain. Number 1 is a neck problem. If we don't evaluate the neck, then we're missing a real potential issue out in the shoulder. Number 2 is impingement. And so where that upper arm comes up and hits the acromion right here, that pinch, there's not a lot of space. So impingement is a big issue. And then finally, posture. Posture is incredibly important for all of these structures and function to do their job. So what does successful natural treatment look like? Again, I'm going to encourage you in a minute to go hit this freeshoulderscreen.com. I want to take a look and see what's going on. I've got a clinic full of therapists. They're fantastic people and they know exactly what they're doing. And we can usually give a person a few ideas on what to do and they can take care of this. It's a lot harder to do this virtually because I just can't see what's happening this way. But number 1, what does successful treatment look like? Number 1, we've got to put our hands on you and move that shoulder around. A lot of, again, traditional therapy places, not discrediting them, they're just not getting their hands on, they're not moving these joints around. And without restoring normal movements of the neck, the collarbone, the first rib, the shoulder blade, if we don't do that and move it by hand, a lot of times we're just not going to get that outcome that we're looking for. So has to have a little bit of piece of that going on. Number 2, there's strengthening is incredibly important. I've talked about it being a mechanical problem. There's some sort of an issue somewhere in all of these structures that's not functioning correctly. And number 1, we have to work on the flexibility. That's where the stretching comes in. And the second piece is the strengthening. We have to get a proper relationship of strength across all of these muscles so that we can use that rotator cuff to keep that golf ball sitting on that golf tee and keep it stable like it's designed to be. So the stretching and strengthening is incredibly important. Lastly, I'm going to bring this up, dry needling or a class 4 laser. We employ both of these. Class 4 laser, the Food and Drug Administration granted us access to use these not too terribly long ago. This is basically the laser that the veterinarians use on horses to deal with their symptoms. They can be very fantastic on dropping that down. I personally feel like we get a lot better job, a lot better response when we use dry needling. Some people are phobic and afraid of needles. They're basically just little acupuncture needles. It's not terrible. But when do we use these? We need to use these whenever your pain is sitting, say, at a 5 out of 10 or better. If your pain is staying that high, then that pain is going to be getting in the way of recovery, of improvement in the pain level of this shoulder. And if the pain is staying there, then we're not going to be able to do the flexibility work. We're not going to be able to do the strengthening piece. By its definition, pain inhibits strength in muscle, and it makes it tight. So pain is number one, what we have to get rid of. I say get rid of. If we can get it down to a 1 or a 2, you know what? Perfect. Then we can address the rest of what's going on. So that dry needling is critical, especially for those elevated pain levels that are getting in the way of doing what needs to happen. So here's what to do next. Number one, I'm gonna recommend this based on your pain. So again, if your pain is sitting at 5 out of 10 or higher, obviously you've recognized, identified that you've got an issue going on. You've ignored it. Maybe you've altered it. It's time to handle it. So here I'm going to recommend that we do a PT evaluation. I'll tell you a little bit about that in a second. If your pain is, hang on, I got ahead of myself. If your pain is sitting down low, a 2 or 3, you know what? That may be a good time whenever it's convenient. Let's schedule a time. Let's have you come in. Let me and my team, let's take a look at it. Let's see what structures are working right, what's working wrong. And a lot of times I'll just give a person some exercise to start with. And that may be enough to get it where it needs to be. If pain isn't the big limiting factor, then fantastic. I had a lady that I saw yesterday that she didn't really have any pain. She just didn't have the strength to lift up anymore. And so if the pain is down and minimal, then we want to talk about a free screen for that. And so, again, I'm going to encourage you to go to freeshoulderscreen.com, and that's where you can arrange this and set this up. When you go there, you're going to go to this page right here. All you have to do is enter your first name and your email. I'm almost positive the phone is optional. I think it was set up that way. But at least your email, that way we know how to get in touch with you. If you want us to call to schedule that appointment, we can do that. So what is the free consultation? Well, I don't do this to everybody that walks in off the street. You've taken the time to look at our stuff on Facebook. You've gotten emails. You've gotten all of this stuff. And so and you've sat through me gibbering and jabbering all this time. So you've done that. I will do the consultation for free. What you get with that, we're going to look at certain movements and see how your shoulder moves to determine what might be causing your rotator cuff pain. We're going to see if there might be something we can do to take care of it naturally. I'm going to give you some tips if we can find something basic that we can work on and pain is low. I'm just going to give you those. At the end, if you decide that you want my help, then so be it. I think that's fantastic. I'm not going to try to sell you on it if the shoulder is giving you enough pain, if you don't choose to do it now. I hate to say it, with the shoulder, at some point you're going to have to deal with it. But I'm not going to try to sell you on it. The whole goal is just to give you information on what's going on with that shoulder and what maybe you could do to handle that. So my offer, again, the difference between a free consultation and evaluation, it really comes down to time. Free consultation, again, we're going to determine the potential cause. We're going to look at, I'm going to say, this is what I would recommend. I would do this, I would do that. I can just show you a few things to work on. It's going to take about 15, 20 minutes to go through that process and give you some ideas. If we move past that, and again, this is what I recommend. If your pain is at a 5 or above, I'm going to recommend the physical therapy, just a full-blown evaluation. That's going to take 45 minutes to an hour. Here, we're going to identify what the movement problem is, what's happening. We're going to go ahead and apply successful treatment. So if pain is elevated, odds are we're going to talk about some dry needling. We may throw in some laser. We're going to do what we need to do to get that pain down without drugs or injections. And then finally, with that, we're going to work through what does a plan of care look like to get this under control. Most people, honestly, with pain sitting above a 5, it takes a good 3 to 4 weeks to get that pain down, get motion back, get mechanics back, and then get strength to where it needs to be. It does take a commitment. A lot of people do want to get that shoulder pain gone with I'm using dry needling again. Want us to dry needle that, get the pain gone so they can get back to normal. Because I have shoulder issues myself, I can tell you that doesn't work. If you don't address the limitation of movement, flexibility, and strength, then it's not going to get there. But we can do a free consultation or a PT evaluation, either one. And so again, I'm going to come back. I've got slots available for free consultations. I've got slots open for evaluations. The evaluations, because they're longer, don't have quite as many of those open, especially immediately. But if your pain is at a 5/10 or more, then we'll make sure that we make that happen. There's my contact information. We've got the office in Mineral Wells. We've got the office, our main office here in Weatherford. So I want to jump back here, and again, this is what you need to do. If that pain is high, we need to get it under control. If it's down minimal, it's a movement issue. Let's talk and let's figure out what's going on, see what we can do, and we'll make that happen as well. So that's the end of what I'm going to provide here. I'm going to ask Ashton to come on and see if there's any questions that I haven't touched on during all of my rambling.
Okay, I've just got 2 questions. One of them I'm actually going to answer.
All right.
Sharon asked if Medicare covers the cost of treatment, and the answer is generally yes. We are in network with Medicare. Medicare does have a 20% coinsurance, so if there's a secondary, then the secondary normally picks up 100%. But Angela is the one who handles all of our insurance verifications, and she's really good at her job. So she always makes sure you know what's going to happen up front. But the short answer is yes, Medicare does cover the cost of treatment. And then the other question was for Luke, if when someone schedules a free screen or an eval, will they always see you?
So I would love to tell that answer is always yes. I'm going to be completely honest. I am no longer the best clinician in the facility. And it is hard for me to say that because I think I'm just pretty good. But I'd also do a great job of teaching our staff that comes in. So our staff, everyone knows what I want done. And I've done, well, number one, they came from really good schools. Number two, I've done a great job of teaching them what they need to know and how they need to apply my 26 years of experience into taking care of these things. It has gotten to a point where they are a lot of times a little bit better than I am on those things. So if you need to see me, and if I'm not either at the Weatherford office or at the Mineral Wells office, as long as scheduling allows, I'd be glad to. If you see Kat, if you see Liz, do not feel like you're getting subpar treatment, because I gladly let them take care of mine when I need mine taken care of, without a doubt. So what I'm going to do, I'm going to leave this screen up probably for another 10 minutes or so. So if you need to write some of this information down, feel free to do that. And I appreciate it, you coming in and listening to me. If you do have questions, we'll hang on to what's going on in the chat or the Q&A box. But you can also feel free to call or text or email us as well. Thanks again for coming out.